This is an exciting topic, and I thank FDRS for inviting me to talk about it. Culinary medicine has been around for about 10 years now, and culinary coaching, which is part of what I'm going to talk about, has been around for about 5. And what's interesting about this is best administered through a team approach. And so, as you'll find out, let's see. Got it. Okay, nothing to disclose. Okay, now imagine that you go to the doctor, and instead of saying, here's a prescription for medication and this and that and the next thing, they say your prescription is to eat more healthy food. We're going to help you plan for meals. We're going to help you shop for meals. We're going to teach you to cook if you need to cook. And you're going to like what you're eating. This is not, you need to eat something that you don't like. You don't like it? Don't eat it, right? This is about eating what you like, making it efficient so that this doesn't interfere with your busy life, and so on. Okay, food is medicine. That's what they're saying now. Food is health. Food is medicine. Food is health. I like that better because what that means is if you eat a healthy diet to begin with, that's preventative. And we know that poor lifestyle habits, dietary included, are responsible for most chronic disease. It's the leading modifiable risk factor. So why wouldn't we want to modify it? Especially obesity and high BMI. And I say that carefully because I know that's, with lipedema, we can say, well, we don't have obesity, we have high BMI, but so. And high plasma fasting glucose, in other words, insulin resistance, type 2 diabetes, and so on and so forth. These are terribly important. And these are reversible with diet, at least to some extent. Another thing, the GLP-1 agonists are wonderful, they're a big help, but the problem is that people that take them to a large extent don't include lifestyle factors. If you don't eat properly, if you don't exercise, you're gonna lose muscle mass, you're gonna end up with malnutrition and so on. And so what you eat becomes important, okay? I'll leave this for you to read. I have a lot to talk about here. Most Americans don't eat enough fruit and vegetables. Most Americans eat too much refined sugar. Most Americans eat too much saturated fat. Most Americans eat too much sodium. And the problem is that our health, I'm going too fast here. Our food manufacturers are more interested in profit than they are in health. And so what they're doing is loading the food with unhealthy additives and so on that make it addictive. Also, it's cheaper. It's cheaper to produce that than it is to produce whole foods. Okay, so food is medicine. What does that mean? Healthy food-based interventions to help prevent, manage, or treat diet-related disease. What's important about this is we're not talking about individual nutrients. We're not talking about how am I going to get more potassium, how am I going to get more of this. People don't eat nutrients, they eat food. And so in culinary medicine, we work with that, with food, with dietary patterns, healthy patterns, rather than working with individual foods. And of course, I put in Dr. Herbst's quote here because I'm no longer, am I still on? I'm still on, okay. We're here at a conference for lipedema and Dercums and Madelungs and FML, and we know that with subcutaneous adipose tissue that it's resistant to dietary changes. You know, in other words, as you know, that if, am I all right here? Okay. As you know, that it's hard to lose this type of tissue just by diet. Okay, and with lipedema and Dercums, as those of you who have it know, it's difficult to control using a diet. It helps to reduce pain and lipedema, no significant reduction in Dercums, although we're learning more how to reduce at least some lipedema tissue with diet. Madelungs, it's not directly related, but if Madelung's patients are obese due to lifestyle factors, meaning how much they eat and exercise, that it makes it more difficult to control the disease, and it doesn't respond to dietary management except for elimination of foods containing alcohol. Insulin resistance and metabolic syndrome, We've heard talks that talked about the benefit of a low-carb diet. Well, that's in the short term, and it has to be low-carb refined, and then we're to have to talk about plant-forward, and I'm going to leave that to Linda Ann Kahn tomorrow to talk about insulin resistance and so on. But in general, that's something that needs to be taken into account. And then, of course, comorbidities like HEDS, POTS, and mast cell with gastrointestinal symptoms. I'm humming up here. Is everything okay with this? Okay. Pardon me? Project a little more. Okay. So what is culinary medicine? I like this quote from the American College of Culinary Medicine: empowering healthier lifestyles and reshaping the course of chronic disease. That's what we want to do. By integrating the science of medicine into culinary tradition, hands-on culinary training, lifestyle lessons using an evidence-based approach, and that's important, that aligns with current medical literature. And I have 5 pages of references for you if you want to look at them. And there's been many more since I did that a month ago. Okay? Incorporating dietary intervention strategies into the practice of medicine to guide patients towards healthier choices. John LaPuma, 2016. Culinary medicine attempts to improve the patient's condition with what he or she regularly eats and drinks, at least to some extent. Special attention is given to how food works in the body as well. This is important. Sociocultural and pleasurable aspects of eating and cooking. People want to eat what they enjoy. Study after study shows if you cook it at home, it's healthier than if you eat it at a restaurant. That's step 1. The objective is to empower the patient to care for himself or herself safely, effectively, and happily, with food and beverage as a primary care technique. And here is, at the end of the day, again, it's about food, and that's what it focuses on. And Ronnie Pollack is important. He pioneered culinary medicine coaching, and he founded the program, the chef program at Harvard Medical School, and that's where I received my training in this, in that certificate program. So, okay, so it always seems impossible until it's done. Thank you to Nelson Mandela for that. And so what do people talk about? What are the constraints that the studies have revealed? Lack of time. I don't have time to plan for meals. I don't have time to shop. I don't have time to cook. I don't know how to cook, or I don't cook very well, or I don't have confidence in my cooking. I don't like cooking. It's costly. Fresh food, whole food is costly. I live in a food desert. I can't get hold of it. Food allergies and intolerances and sensitivities. Food preferences. What you told me to eat, I don't like it, and it violates my cultural or religious beliefs. And the one that studies haven't talked about is chronic disease issues. When you prepare food, you're standing for a long time. Heavy arms, heavy legs. It's very tiring. And I thank everybody who responded to my survey that I posted. And I have 25 respondents so far, and I apologize for the typos. I tried to fix them, and it didn't pick it up. The major ones: I don't have time to plan and shop for meals. I don't have time to prepare food at home. I don't enjoy cooking. Well, you're not going to like it if you don't like what you're eating. And the one that most respondents chose: food preparation is too tiring because I have to stand up or use my arms for long periods of time. And I also thank the people who responded to my question on the community board, and I asked, what is the primary obstacle to eating healthy? A lot of people said food sensitivities. Well, then what I say to you is, if you're sensitive to something, let's not talk about what you don't want to eat or can't eat. Let's talk about what you do like and can eat. A lot of people talked about the fact that families aren't helping out. There's a way to handle that, and so on and so forth. So thank you to everybody who answered. Okay, so what are the benefits of cooking at home? Obviously, you're going to eat better, you're going to have better diet, better food choices, you have more control over it. And this is especially this: the more you cook at home, the healthier your diet's going to be. The longer you take to cook, if you can do that. More frequent cooking from scratch, and here we're talking about a whole food diet, okay? enjoyment of cooking. You're going to enjoy it more if you're more comfortable with it and you like what you're eating. Higher consumption of vegetables, obviously, lower consumption of ultra-processed food, and so on. So cooking at home empowers patients. And especially if you are organized and you manage your time, meal planning saves time. It cuts food costs. It facilitates batch cooking. Why only cook for one meal when you're cooking? Why not cook for multiple meals? It reduces the stress of last-minute meal preparation. And it's less money. So if you think about it, for instance, I shop once a week at the local Persian market. And I like them because they have a huge variety of produce, and they always have something for $2 or $3 that I can get, like 5 organic zucchini or 8 organic bell peppers or whatever. And I bring them home and I think, wow, what am I going to cook this week? And it takes a little planning, doesn't it? And so what you do is you sit down at the beginning of the week and you say, what am I going to cook and what can I use this for? I'm going to maybe, let's say I'm going to make, for instance, not with those things, but I'm going to make some hummus, and I'm going to make some roasted vegetables. Oh, I can then wrap them, right? I can make a wrap with tortilla, with hummus, with roasted vegetables. I can freeze the roasted vegetables. There's so many things you can do, and then when I come home, I have in my freezer a packet of rice that's frozen, a packet of roasted vegetables that's frozen, all these different things. And so just by taking a little more time and making a little more food, I can take them out, put them in the microwave or whatever, and I have a good meal in a few minutes. That's about planning, and that's about batch cooking. Okay, he is my poster child for what not to do, okay? Working adults spend the least time preparing food because it's all about convenience. It doesn't have to be. That means that their diets are not as good. They eat at fast food restaurants more. They spend more money on restaurant food. They're eating more ultra-processed food. Working adults can eat healthy diets and eat what they like if they plan ahead. If they cook things that are quick and easy and delicious to them and healthy. If they batch cook, and so on and so forth. Okay, I did this study. I was curious. About 2 months ago, I looked at McDonald's Quarter Pounder with cheese meal supersized, and I went shopping online at the local Publix supermarket, which is near this hotel, and I bought food online from McDonald's, and I figured out exactly how the nutrition stacks up. The only thing is, I think I've got a typo on there because it shows very little fiber for home cooked, and that wouldn't be the case. But McDonald's is very forthcoming with their nutritional information, which I appreciate. And for everybody that loves McDonald's fries, know that you're also eating beef broth and milk solids, okay? And what did I find out? Well, this is not a healthy meal to begin with. But if somebody comes to me and says, this is what I love eating, then I could say to them, you can cook this at home. You can use healthier cooking methods. You can control what goes into it. You're still going to get your hamburger with cheese and all that kind of stuff. You're still going to get your fries, but instead of frying them in oil, you're going to bake them in the oven. Instead of putting your hamburger on the grill, you're going to cook it in a healthier way. And so on and so forth. Instead of eating whatever ketchup they throw on it, you're going to have something without high fructose corn syrup, and so on. So when someone comes to you like this, you don't say, clean out your cupboards, we're starting over again, you're going to eat all vegetables from now on. You say, no, let's take one baby step. Try cooking this at home, because it's going to build self-efficacy. You're going to say, I can do that, and it was good. What are you willing to try next? So some people are willing to just clean out the cupboards, but with most people, it's baby step after baby step after baby step, building self-efficacy, having them realize they can eat at home, they can enjoy what they eat. It isn't hard to cook, and one of the things that I do as a culinary medicine coach is I can actually teach people to cook, which is great fun to me because not fancy French cooking, just basic, because one of the barriers people have, which they don't really like to admit, is I'm not confident, I don't know how to cook. So, okay, this is a team approach, as I said. the physician or the nurse practitioner or other healthcare provider says to the patient, you have to eat healthier. You have to eat more veggies, you have to cut your sodium, whatever it is. And they might refer them to a nutritionist or other registered dietitian for specific dietary guidance. And then they refer them to a culinary medicine coach who helps them, number one, identify the barriers. What is it that makes you hesitant to eat healthy? What is it you think you can't do? What are you afraid to do? What don't you know how to do? So that's the coaching part. And then, what do you need a little bit of assistance with? Do you not know how to plan meals? Do you not know how to read recipes? Do you not know how to do basic cooking? Do you not know how to batch cook? You know, all these different things that make it so much easier once you know how to do it. And they're not hard. Cooking classes and teaching kitchens can be virtually or in person. You use motivational interviewing strategies and health coaching techniques for sustained behavioral change, because what we're trying to do is to convince people you're not going to do this in the short term, that this is something you're going to take ownership of. And you're going to learn to enjoy doing this. You're going to be proud of yourself. You're going to enjoy the fruits of your labors. So in teaching kitchens or cooking classes, which you can do online, nutrition education, basic cooking skills, physical activity, you can touch on that, mindfulness in eating, web-based resources and technologies to access recipes and nutrition facts, how to read the labels, how to understand what you're reading, so on and so forth. It improves attitudes, it improves self-efficacy, and that carries over. People eat healthier. You facilitate lifestyle changes, diet quality, confidence in tasting new foods, mindful eating, and self-care. Important. That's what it all boils down to. Telehealth interventions. Studies show it works. It works. It doesn't have to be in person. It accommodates patients who would have barriers, transportation costs, time of day, mobility, so on and so forth. The participant can cook along with the instructor or just watch. They're in their own kitchen. It's much more comfortable to be in your own kitchen using your own utensils. They can record it and play it multiple times. I put a sample recipe online, and if you take a picture of the QR code now or when it goes online, on YouTube, that there's a sample recipe that I use when I work with clients. And what's good about it is it takes 15 minutes to prep, it takes 15 minutes to cook. It's healthy, it's whole foods, so on and so forth. So if you click on that QR code, you go to my website, go to the nav links, and click on FDRS recipe, and you'll find it. Okay, tips to share with parents: commit to cooking, or patients, commit to cooking more often, cook food for multiple meals, plan and shop ahead of time, organize your kitchen to promote healthy eating, try healthy new foods, learn how to integrate them into your meals, plan meals using produce in season, fresher, more nutrition, less expensive, and choose recipes that are quick and easy to prepare, inexpensive, and that taste good to you, okay? Lots of references. Okay, thank you.
Marty, we do have a couple questions.
All right.
Number one, have you considered the impact of executive dysfunction, such as ADHD, and a lack of interest in food as a barrier to managing meal planning, shopping, and preparing of foods at home? This represents an enormous barrier for some.
It does. And so what you're working with is working with them through a conversation. And first of all, with regards to lack of interest in food, trying to find out something. What sounds good to you? Just one thing, okay? And saying, let's try making this one thing, take ownership of it, because when they say, oh, this wasn't hard, and let's do something that's really quick and really easy. And when you're working with culinary coaching, you don't necessarily start with the healthiest alternative. First, you start with anything. And so if somebody says, I love whatever it is, I love onion dip, okay? I like onion dip, but let's make onion dip. It's easy. And I'll show you, you can do this in just a couple of minutes. Oh, I could. And you could do this anytime you want. And so each little step goes a little bit farther.
Another question, how to monitor the best whether you get enough of nutrients?
That is beyond the scope of practice for culinary medicine. That is when you talk to a nutritionist or other registered dietitian.
Thank you very much, Marty.
Thank you.
Well, that concludes our morning sessions. We are going to break for